Richard. So thank you, the organizers, for inviting me. I'm from Heidelberg. Heidelberg is the oldest university in Germany, so it has a long history, similar to maybe Cambridge, and it's by incident the partner city of Cambridge. So that is a scene from around 1960s where you see the elegant British guy and the more like traditional German one inviting him. So I'm a clinician, cardiologist, so don't ask me please equations. So if you ask me equations, I will invite you to Heidelberg and you have to do heart intervention. So please be aware and careful. Why are we going to talk about modeling? So we often have patients like this patient suffering severe heart failure. He had in his previous history a mechanical valve and he has several points of regurgitation, so it's a high risk to operate them openly, so we place some plugs into those holes to occlude them and to leverage the potential of hemodynamic improvement for his heart muscle function. This is a scene from last year. Here's a pregnant lady in her 13th month of fertility. Here's the picture of a baby. What we've done is she suffered from severe heart failure due to hypertrophic cardiomyopathy and LVOT obstruction. So you see that SAM phenomenon, a severe regurgitation, and she had lung edema, and she was shortly before having a really severe problem. So what we did is an intervention. We induced a myocardial infarction right at the right point in the myocardium, and you see afterwards the outflow tract obstruction was gone, and 2 days after that she could be released from the intensive care unit. Or you see this situation here. My colleague Eberhard is working here on a patient equipped with an ECMO machine and an impeller, so that's two assist systems to stabilize a patient who suffered severe arrhythmias. Up to 60 times a day we had to shock him with a defibrillator, an electric storm situation, and severe heart failure. And you see the mapping endocardial that was not able to really ablate it. We tried everything, so everything was just tried by our limited evidence in such cases, and nothing did work. What we did do is we put him into a big machine, into a stereotactic radioablation, so we did put X-ray bursts on that side, and we silenced the arrhythmia. Or this case, the movie may be working in a little second. So Heidelberg invented the outpatient emergency system in Germany, and you have here a resuscitation situation where the heart is not working from alone, so you have to compress him from the outside due to a myocardial infarction. So every situation is heart failure, and the main issues for me as a clinician is, do we really understand the physiology in each of those cases? The outcome is largely based on decision making from individuals and the individual skills in those interventional procedures. We have a multimodal assessment, as I showed you, but we have sometimes minutes or a few hours or days to make the right decision. So that's everything very subjective, and the predictive capabilities are limited in our clinical workflow. So I'm coming as a cardiologist from the genomic side, so we have many networks on genomics of heart failure, and as you can see, data sciences become more and more important because the amount of data and the complexity of the systems becomes more important. So in 1998, my colleague Grünig, he published a study on just a familial background of heart failure, and that was very trivial. It's a clinical based study involving no technology. And nowadays we use that next-gen sequencing to really understand what's behind that. What are the mechanisms? So for instance, here in heart failure due to ischemia or to dilated cardiomyopathy, we could identify basically same genetic regions that drive the risk of failing hearts. So we built up a strategy, a translational strategy, to understand the mechanistics on the biological side with biological models, and enrich those models by the human data from open sources but also experimental data, and then go back to humans, like here in this disease gene which David Hassel from our institute identified, which is now a well-known cardiomyopathy disease gene. So the amount of data in clinical situations is very important. Here's an example from the UK Biobank, where you can see if you have limited data sets from 5,000 persons and you just try to make a risk stratification of systolic blood pressure and the age group, it's impossible to see the mathematics behind that. But if you increase that in the order of magnitudes, you will see the pattern behind that. So we need precise and we need large data sets to solve some solutions, and we have done that in European concerts here, like many national and international collaborations to enhance the amount of patients. And we are currently in the range of thousands, which we investigated genome-wide. Here, for instance, just if you have that sarcomere, we understand now where is genetic variation leading to heart failure. So what is the next stage in genetic research? I believe it's partially in deep learning based methods. Here you see the principle which you all understand. You have an input, you have, let's say that's the dendrites, you have the body of the neuron and then the axon as the output, and you combine many of those layers in silico, and then you get a similar behavior as the human brain. So this paper used that to use the inference of common primate variants, so in apes and other monkeys, and they hypothesized if the variant is the same in humans and primates, it cannot be that detrimental. And what they did is they took a combination of modeling, for instance secondary structure prediction models, and deep learning to really harvest that information of similarity between genomes to best predict by now which of a missense variant is, let's say, disease causing. So that's very important for our patients to reflect that. So we increase the density of our genomic models by now having also structural variations which we investigate in genome sequences. So we try to have several hundred and thousand of individuals having a good classified disease and try to solve their genomics. So the amount of data is here like a couple of a floppy disk which you would have to store. So we have other storage systems as you have. So we try now to make a multi-scale approach to that genetic disorders in incorporating different levels of biology. Here, most easy you take expression of the left ventricle, so we take tiny biopsies of the heart and we can link the genomic situation with the expression. And that helps us really to understand what are individual drivers in patients, maybe only in the myocardium, but not for other tissues or diseases. And we use epigenetic information and combine that in the very same patient. So by now you can take one tiny biopsy, you can do a metabolome, a proteome, RNA sequencing, and also methylation analysis from, let's say, a 1 millimeter tiny biopsy. And what you get out of that is, for instance, here markers. That's a gene that is epigenetically regulated in heart failure, which we identified. And if you resemble that situation in a zebrafish, a very ordinary model system for heart failure, then you see exactly that you can reproduce a human situation. So at least that points towards a functional implication in the whole process. So what we have done with partners like here Andreas Keller and also Siemens as a health company in Germany and worldwide is to detect biomarkers that can help us to discern different diseases and different stages of the disease. And I think that's in the best sense of what Obama initiated in US, like the precision medicine strategy, which is based really on the identification of uncertainties and also dissimilarities between patients. So we have several of those biomarkers which we developed for heart failure, and you can see here on this sketch on the left side that the number of studies internationally that use biomarkers or precision medicine strategies increases exponentially. So you have not now the mass medicine, but you try to isolate individuals that are distinct from each other to really identify, maybe by a modeling approach, what is the etiology or the best medication in individuals. Very interesting times for a cardiomyopathy researcher, because now we have a panel of phase 1, phase 2 and phase 3 molecular trials that are targeting those subgroups. So we are not only detecting a disease subset, but we also can put that patients to those diseases. For instance, here is a therapy for dystrophinopathy, a severe muscle disorder of the skeletal muscle and also the heart. And that therapy blocks distinct mutations. It's an exon skipping therapy by an oligonucleotide. And you can see you can re-express a shortened dystrophin in those muscles. It's only around 1%, which you can measure from a normal situation, but that 1% may be sufficient to withhold the disease for a couple of times. And here you see from the EMA data that patients in external control with that disease, they have no walking activity after 2 years because they are dead. And you see the treated ones, it's suggestive that they have a better outcome. So other companies in the field, like in San Francisco, a company called Myocardia, they have a whole range of agents directly targeting molecular mechanisms of heart failure, like the sarcomere, like myosin and others. So we have now that vast amount of information from the etiology and the mechanistics of cardiomyopathy and heart failure, and we want to have that precision medicine strategies, but also risk stratification. And of course, if you want to harvest that power, you need a model. Yeah, and that model can be a regression-based model or a numerical simulation, or it can be machine learning. So somehow we need to incorporate really information processing systems into our clinical workflows. So here you see the rise in machine learning, for instance, publications. So what are we doing in Heidelberg? So Germans are used to have a different way of data exchange. They drive very fast on the Autobahn, or they go to the football stadium, but they also can go digital. We in Heidelberg have founded computational cardiology units and a professorship in early 2013, and that was Alan working on our first computer cluster in the cardiology department. And I think since then much developed, and our strategies are going to the next level, because we try now to rebuild everything. So that's a new heart center we are currently planning. So that's the first sketches from the architects. And in that heart center, you see here a research institute. So that's Informatics for Life, and it's directly linked into the workflows of the heart center. So if you now have a researcher doing data analytics, he is equally important to really drive the workflows and the data generation as a doctor is or a nurse. So we want to generate really a powerhouse for phenotyping, for scientists and doctors and nurses, and also for patients. So, and we have a lot of patient contacts. We see around then 75,000 outpatients per year and 60,000 inpatients for cardiovascular procedures. So that's really going into the dimension of at least bigger data. So I think it's fundamental that we take that biomedical expertise and combine it with guys from mathematics, statistics, and computer sciences. And we try to understand each other and to work in tandems. So what we do a lot in Heidelberg, because we believe it's essential for understanding the heart, is MRI. You see here the number. We have 2 MRI scanners only for the heart, and we now do around 3,000 examinations by MRI with the 2 machines per year. So we are very good now on genetic markers, on phenotyping, but we also want to understand, of course, the longitudinal dynamics of disease and of patients. And that's underappreciated, I believe, in the history of medicine, because you see the patient very cross-sectional and not longitudinal in your practice. So what helps is to understand activity. Here you see just the accelerometers that are in devices like iPhones or in Apple Watches. And you can see what you can do with machine learning models to understand from this group here what activity translates into, by an algorithm, into the classification of sitting, walking, or having other issues like falling. You can even dance very elegantly. So that information is really helpful to understand activity of heart failure patients. So you see that the 6-minute walking test, a very good discriminator of the prognosis of heart failure patients, really goes well along with treadmill exercise testing, but also with a mean step count. So if you now have recordings of every day of different of those measures, we might be coming into that dimension of Star Trek, where you have the tiny machine and you can diagnose the diseases on the side, on the patient. So that's of course a dream. There are different challenges. One of the challenge was really impressively solved by Apple together with Stanford. I was once the study participant of 490,000 ones. So that's the largest study ever on diagnostics in any disease. So that's really an important milestone, even though there are severe limitations, of course, in that early stage, but they assess just the pulse of Apple Watch wearers, and they later on incorporated also the ECG feature, which you might know. And we are at the clinics really confronted with those patients. Like here in German, it's an order for an examination, and that order reads, please control the pacemaker of the patient because the smartphone says the heart frequency is abnormal. So the smartphone is more trusted than that highly medical grade device. And of course, the smartphone was wrong in that case. The pacemaker did function, but still it's the discussion. Like Angela Merkel in Germany said, we need big data, we have that GDPR, we need to go around that. Big data is important. And Steve Wozniak here from Apple, one of the founders, he said, no, Angela Merkel, you are wrong, you need smart data. So invest in smart systems and in smart persons. And I think that's totally right. So what we have done here in our department, here again, Eberhard Scholz from the electrophysiology team, he used single lead recordings of ECG like it comes from the Apple Watch now. And what you see is atrial fibrillation. And every doctor here in the room, so I think I'm the only one, would say that's atrial fibrillation. But actually it's atrial flutter, a very different arrhythmia. And it's important for your modeling to discern atrial fibrillation and flutter. And what he has done is a machine learning simulation based approach, where he really has that multi-level AV block concept to really show that the ground truth here, the intracardiac mapping, is a flutter and not a fibrillation. And they went further on, so here you see the spreading of diseases, and all that links between the different colors are actually the spreading speed of the disease. But the spreading speed is not equal to the distance on a geographical position, but it's reflected by the international flight connections. So what they do is they simulate flight connections in the heart. They measure arrhythmia points with a catheter, and what they do, they just build the correlation of the timing of the impulse between all that sites. And what they then do, they select the best next step or point to measure from that correlation graphics. And that is shown here. If a cardiologist searches for that arrhythmia, he needs 27 iterations, 20 times placing the catheter on a different side. And their algorithm is able, after 7 iterations, to tell the cardiologist exactly where the spot is where he needs to ablate. Other team is from Sandy Engelhardt, who is a young professor. She is very talented in using artificial intelligence networks, like we heard in the talks before. So she has convinced us to use in training hyper-realistic simulations of the heart. What she does is she has constructed a simulator where you have a very crude membrane which reflects the mitral valve. What she is doing, she constructed a framework for artificial intelligence, and she enriches those silicon membrane by real surgery microscopes. So you have then a hyperistic simulation by looking into that object, and you can see here 6 pictures, and I think you cannot really tell which one is a simulation and which one is real. And that's a video of such a procedure. I have done it. I'm intervention cardiologist, but I was allowed to do stitches. And actually you can see here what you really see, that is what you really have. And you can do that domain transfer, also vice versa, and the computer reconstructs the artificial situation. So very interesting times using that machine learning approaches. So the holy grail would now to simulate the whole galaxy, and if you simulate the galaxy, you also simulated the human and the heart. So that's maybe too intensive, but we want to really understand the connectivity between that different layers going from the gene to the families. So in one project we worked together with Siemens, and they are really good in Princeton in model development, and Tiziano is here in the room. He is part of that team from Tommaso Manzi and Dorian Comaniciu, and that was very interesting. So we had that dream to develop a heart failure model, to validate it, and to do a production model for different use case studies. For instance, cardiac resonation, as Pablo already said. So from the data processing segmentation, there was a forward model, and the parameter estimation was partly made by a self-taught artificial intelligence agent to really save time and also save processing power. What was maybe unique is that all patients were characterized very carefully also on a hemodynamic scale. So we had LV and RV pressures, we had resistance from the organs, from pulmonary and from the whole system, and we could enrich the model just by fitting that to the real pressure situation. The action potential was a lump model of electrophysiology, so very primitive, I guess, when I heard all the interesting talks on electrophysiology. But still, we used some clever things, I think. So we used MRI to really detect the torso and then simulate the ECG electrodes on that real torso of the patient, because patient anatomy is very variable in those diseases. So here you can see an example of QRS duration or the electrical axis. So if you have a fixed initialization of that model, it's quite a huge error. And if you train that set or make the full personalization, of course, that error goes down more for the QRS duration as for the axis. So that was for us interesting to understand that we can simulate electrophysiology and also the other stages. So we have that input, we have anatomy, electrophysiology, biomechanics, and hemodynamics, and of course then we have, as all of you, the outputs. So we have done that for a cohort of, I think it's over 100 patients at the end, where we now of course calculated sensitivity analysis, but also calculated the different shape forms of the hearts which we extracted from that personalization strategy. And as you can see, it's in good agreement because it was also fitted to the parameters with what you measure in the MRI. So those are the different hearts, and Stephen has a nice poster showed me yesterday where he has a collection of those hearts with even more precision based on CT. Those were based on MRI. And what you now can do is you can, for instance, in this Hill equation, do an extraction of the contraction strength, the active force, for instance, or also stiffness parameters here correlated to tau, which is a measure in the cath lab for diastolic function. So you now can understand those basic principles and also select them as potential surrogate marker for further things. So here again, our model. This time we compared the regression model from the clinical data. That's a Seattle heart failure score, so the likelihood of death after 5 years of such a patient, and we compared it to our numerical model. And you can see here, at least it's a good correlation between the both. So there is indication that some model parameters could be a very good measure of the outcome of the patient. One observation is also from the mechanical activation pattern that you can discern different block patterns. So if you have a left bundle branch block or right bundle or a diverse intracardiac block, you can see that on the model. And as Pablo alluded, CRT is a big problem because it's a very effective therapy in the right patient, and it's complication burn in patients that are non-responders. So you should really select the best patient, even if they are not fitting the guideline pictures. You can optimize CRT pacing protocols, not on the patient side, but maybe on the model. You can probe the localization in the simulation and then try to reach that position in the CRT simulation or in the real implantation. And of course, you have that diverse scar formations in heart failure, which you also can attribute in your model. So this work is under construction still, but of course we have a virtual implantation of the diverse leads in that model here without atria, and of course then you can do a CRT lead stimulation. And here you can see the agreement between biventricular pacing, RV-only pacing, and other pacing protocols, and here always what we measured and what we computed beforehand. So it's quite good that you understand that the effect of the simulation translates actually what you can do in pacemaker programming, and that was very powerful to us to also measure, let's say, ejection fraction or systolic ejection times in those patients by just manipulating the protocol. And here you can see that nicely visualized, pre-CRT implantation and post-CRT implantation, and that was that one video which I think is very informative. So here you see the bundle branch block, the initiation, and the wave starts here on the right side, and here in CRT you have then a coordinated contraction again. So what is unique about that project? As I alluded beforehand, we have all that omics scale data. So for each patient we have the phenotyping, but we also have that molecular information from genome to epigenome to mRNA and so on. So what we dream of to enrich now the models by molecular information, and I think that would be a next step to maybe reduce uncertainty. So this is an English guy here. He is a physiologist of the muscle, and his statement, exceedingly simple in principle but wonderfully complicated in detail, is from the muscle study of his own, and I think that's really for me always fascinating, how complex things are, but also how beautiful they can be. So this is my team. That's not only participating, but also a lot of guys from Heidelberg, from Informatics for Life, now from Stanford, and also from Siemens, who really contributed a lot of the technology work. So, and if you have an equation question, Tiziano is happy to take that. Thank you.
We've got time for one or two questions.
Is that you on the left, Richard?
This one.
I don't remember the occasion of it.
I'm hiding behind, so I'm the least important one.
So fantastic talk. Thank you for coming. It's one of the questions we have when we pitch these ideas and we sell them to our funding bodies is that we're going to tell these cardiologists that if you give CRT to this patient, there's a 70% chance that it will be successful, let's say, if we put uncertainty quantification in. Yet the decision is so binary. So as a cardiologist, is it useful to be told, I'm 70% confident, or do you just want a binary, green light, red light, let's put this in, let's not put this in?
Binary decisions are very old school in medicine. So we are living in the age of precision medicine, that binary decision taking, and we go more to probabilities. So for instance, in sudden cardiac death prediction, hypertrophic cardiomyopathy, we use, let's say, a linear model of risk. So we have then an absolute risk or a relative risk within 5-year time frame, and we make our decision by selecting acceptable risks, which might be very different in different persons. So if you have then the granny with 85 years and she says, okay, that risk is well taken for me, that's completely different if you have a sports guy, athletics, and he really has a lot to do and he wants to be protected even with a lower risk. So for us, it's really, we want to leave those binary things, because I think if you have an ejection fraction of 29 or of 30%, that does not change your biology, but it changes all decisions currently made. And that's a problem. So, but don't name it anything uncertainty quantification. Just say risk. That's fine for a cardiologist.
Benjamin, thanks for the talk. I really enjoyed it. One of the things I don't know, it's what is the promise and what is the reality of the big omics, let's say, trend. And I read things about being as always many times happens, that it's big promises and it's difficult to meet all the expectations. I've heard about only being able to really tackle very narrow cancer types, and the rest is it's the initial of a very long causal chain, and it's not that revealing. and we need to fill those gaps. You seem to be a really prime position to know, or to give your opinion at least, of how much of the potential is in that omics, and what is the balance between how much to digest and how much to still investigate.
I refer to the electrophysiology model, which we heard in the morning, with the 35 channels. If you look in our omics data, how many of the patients have different expression levels, and also if you go riboseq data, so really protein translation, then you see how different that picture is. So you never can capture that from the surface ECG or something else, so you need that molecular information to really understand the fluctuations in those patients. And that's reality in the clinics. We treat the same patient with the same antiarrhythmic, and one gets a problem and the other gets a cure. So I think that information is really underappreciated, but it's not only a hype, that's saying. So of course some people just do it because it's super cool. Other things, it's like a normal control you would do. So if you treat a patient with a targeted therapy in the heart muscle, which can have severe consequences, I think you must understand what's going on in that heart muscle. Yeah. For instance, we see in RBM mutation carriers severe missplicing of a collection of channels, but also on structural genes like titin, and that has severe consequences for the mechanics of the heart and also the electrophysiology. So I believe that's just getting normal now. So if you now sell a paper having genome and transcriptome, that's not multi-omics, that's normal. So if you have 4 or 5 of those layers, then you still can call it multi-omics. But I think it's useful information.
Okay, well let's thank you.